Hi, everyone. We're going to get started in just a minute. All right, looks like everyone is mostly joined. Welcome, everyone, to the June Rural HPV Vaccination Learning Community. We, on behalf of the American Cancer Society and the ACS National HPV Vaccination Roundtable, we want to thank you for taking time with us today. This session will be offering live CME and CNE credits for today's session. And today we're going to cover the final stages of the quality improvement framework. I do want to note that this program is supported by a grant from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. Next slide. I am Tina Turpin, and I'm a director for the National HPV Vaccination Roundtable, and I'm going to be welcoming you and closing you out today. But I am a part of a larger team, Ashley Locke, that you're going to get to hear from after I speak, as well as Katie Crawford and Hannah Nine. So a big thank you to both of them. Next slide. We love a good icebreaker here at the American Cancer Society. So in the chat, can you please share your name, organization, and dream getaway? Oh, I see some Greece in there, Scotland, New Zealand. Okay. Fiji. Oh, Fiji feels nice right now. All right, I'll let those keep rolling in and let's go to the next slide. So here is our packed agenda for today. In just a minute, I'm going to hand it over to Ashley Locke, who's going to quickly review a few items from session 3. Then she is going to review evidence-based interventions, PDSA cycles, and sustainability. And then we're going to hear from several partners to talk through their interventions on a panel discussion, also moderated by Ashley. And then I'll wrap up with a few reminders. So I do want to share a few things before we get started. All rural HPV vaccination learning community sessions are recorded and posted to a public-facing website. So please turn off your camera if you don't want your image recorded. This session is certified for live CME and CNE credit. We have added a link to the chat detailing out CME information for today's session, and I do want to note none of the planners or speakers for today's session have anything to disclose. And last, we ask all participants to stay muted until our panel discussion. However, the Zoom chat will be open for questions and support if you need it. Next slide. For today's session, we're going to be focused on the following learning objectives. List evidence-based interventions to increase HPV vaccinations in your community. Describe how to increase on-time HPV vaccination rates in rural communities. And compare best practices and challenges in increasing HPV vaccination in rural settings. Next slide. Before we get started, we would love to do a pre-session poll. So that is going to launch right now. And we'll give that a few minutes for you guys to respond. There's a question in there and a knowledge check for you guys. Give that another minute. I'm going to read through some more vacation spots. Looks like we have most coming in at yes, 1 to 2 changes occurred, which is great. All right, we'll leave that up for just another minute. We're about 60% right now. All right, looks like we're evening out. We can go ahead and close the poll. and move to the next slide. And I would love to hand it over to the amazing Ashley Locke to take us through the review and the presentation. Ashley.
Perfect. Thank you so much, Tina. So last month we showcased our quality improvement framework. If you want to go to the next slide, this is that framework that we shared. If you want to go to the next slide, we reviewed the beginning stages of the framework, which we call capacity building. And during this stage, we reviewed current processes to help strengthen systems, infrastructure, and staff to help improve HPV vaccination uptake. This stage includes data, building a quality improvement team, setting a goal, creating an action plan, mapping out your current processes and workflows, and lastly, identifying gaps and opportunities using fishbone diagram and 5 whys. Next slide. So these were just some key takeaways that we shared last month, and I want to talk through them quickly with you again. So following this framework is very important. It's knowing where you stand empowers us to select the most effective evidence-based interventions, and this is really crucial for making impactful changes in our rates. The data specifically helps us to know where we're at. It helps us to show impact and tell stories. Additionally, it's essential to have robust teams with vested members who touch the different steps in a process to help put together that goal or that aim statement and action plan to work towards. And process maps not only allow us to document workflows, but help us identify redundancies. And once they're finished and complete, can also be a training tool for new staff. And lastly, knowing your gaps and your root causes help you to choose the best evidence-based interventions and process changes to impact your rates. These takeaways are pivotal in ensuring we not only understand our challenges, but also actively work towards effective solutions. So if you want to go to the next slide. So once we know our gaps and our opportunities, it's time to really identify sustainable evidence-based interventions, and that's what we're going to talk about today. If you want to go to the next slide. So during today's session, we'll be viewing the latter half of our framework, which is going to be evidence-based interventions. We're going to talk about testing out changes through PDSA cycles, and then also sustainability. Next slide. So I first want to ground us in what evidence-based interventions are, and they're also known as EBIs for short, so I may use both terms interchangeably. So they're proven methods for prevention or treatment that are backed by peer-reviewed research that can significantly elevate our outcomes. They don't just offer theoretical benefits, but provide documented proof of effectiveness. You may have also heard the term evidence-informed interventions used before. So EBIs and evidence-informed interventions are not one of the same, as evidence-informed practices use the best available evidence along with professional expertise, community preferences, and local context to guide decisions rather than relying on one single established intervention. So what makes EBIs really important? They increase the likelihood of success. By grounding our approaches in solid evidence, we enhance our chances of achieving our goals. They're cost efficient, so by relying on strategies that have been tested and proven, we save precious time and resources during both the planning and implementation phases. And also, utilizing EBIs adds credibility and substance when sharing our plans with stakeholders. It clearly defines what we're evaluating and highlights our expected impacts. So as we move forward, keep these advantages in mind because they'll help to guide our discussion on implementing EBIs effectively in our HPV vaccination programs. So next slide. So there are 3 buckets of evidence-based interventions. They're patient-directed, provider-directed, and increasing community access. So we know that interventions are best when done in combination. And so today I'm going to spend time talking about these 3 different buckets and the interventions that are within them. Next slide. So before we go into depth on interventions, I do want to take a minute to have each of you share via our poll which interventions you have implemented around HPV vaccination, and you have the opportunity to select all that apply. So feel free to share with us. So we're slowly getting participation. So far, it seems like a lot of you have done professional education, especially around that effective recommendation. Also, professional education on the HPV vaccine series at age 9. Patient and parent education. We're about 52%. So feel free to please share. We will be using polls quite a bit today. So um, be prepared for a couple more to come here shortly. But it just allows us to kind of see where everyone's at and also hopefully keeps you all engaged in the conversation. Just give it a couple more seconds. Would love to get a few more of you to participate if possible. All right, we can go ahead and end the poll and go ahead and share out the results too. But it looks like most of you chose professional education and then parent and patient education along with all the others as well. So thank you for participating today. And we can go ahead to the next slide. So we just talked through, obviously, those larger buckets of interventions, and this slide in particular looks specifically at evidence-based interventions that are meant to increase HPV vaccinations. So I'm going to go through each intervention specifically. Okay, next slide. So let's review patient-directed interventions first. So we're going to talk about the importance of patient reminders specifically. So these are crucial for increasing vaccination rates by keeping individuals informed about their preventative measures like the HPV vaccine. And these reminders can take the form of written notifications or phone calls, including automated messages. It's essential to use a variety of media and languages to ensure everyone receives the same message. This diversity not only broadens our reach, but also makes the reminders more effective. Plus, tracking the effectiveness of these messages allows us to refine our approach over time. And research has shown that effective reminder calls can lead to significant increases in vaccination rates. And as we consider patient reminders, think about how you can implement them in your own practice. How can we ensure that our reminders are not only informative, but also engaging? So maybe it's implementing a birthday campaign at age 9 to remind parents their child is due for the HPV vaccine. It's something that's unique and different that they may not expect to see from you. Next slide. So beyond reminders, patient education using small media is also important. This approach in particular includes videos, printed materials, and social media, all designed to inform and motivate individuals about the HPV vaccine. These materials can be direct, so it could be using a brochure to have a conversation with a patient about the HPV vaccine, or they can be indirect via a poster on the wall or a social media message that's posted on Facebook or Instagram. So just a few things to consider when you are planning for this type of intervention. First is health literacy. You need to know and assess the health literacy of your target population. This ensures that the message is appropriate and it's effective. Making sure you have proper visual representation, so selecting materials that use images that reflect your target population is very crucial. It enhances reliability and engagement. Also, workflow integration. So thinking about how these small media pieces can be seamlessly integrated into the workflow of your care team, especially if you're using, let's say, a brochure with parents to talk about the HPV vaccine. It's important to think about action after introducing the topic. If they say yes, what will we do next? Lastly, always ensure that the materials are updated based on the most current recommendations. This keeps our information relevant and trustworthy. And by leveraging small media messages effectively, we can significantly increase awareness and motivation around HPV vaccination. So remember Charlie's story? I shared it back in April. It was an HPV vaccination poster on the clinic wall that motivated him to convince his mom to get the HPV vaccine. Next slide. So I do want to acknowledge before we go into provider-directed interventions that patient incentives is also considered a patient-directed intervention, but we're going to talk a little bit more through some patient incentives in upcoming slides. They sort of overlap with building community access. So we can go to the next slide and we'll start with provider recommendations. So what you say matters and how you say it matters a lot. So remember that the way we start a vaccine conversation with parents can significantly impact uptake. Although this slide explicitly says provider recommendation, all staff should be providing a strong HPV vaccination recommendation to adolescents and parents starting at age 9. Everyone in that medical home is considered a trusted messenger, and so the message should be the same across the board. It's really important to start by using a presumptive approach and framing the discussion around cancer prevention, which really resonates deeply with parents. If you encounter hesitant parents, it's essential to ask about their main concerns. Don't shy away from their questions. This openness shows respect and fosters a supportive dialogue. Remember, often a brief research tested message can ease their worries, so it could just be a 1 to 2 sentence that can make all the difference in the world. And lastly, if a parent does decline a vaccine, don't be discouraged. Remarkably, research shows that 70% of those who initially say no will eventually say yes, and if they're given another opportunity. Provider recommendations in HPV education is not a one-time intervention. It's meant to be continuous and as needs arise. So be ready to bring it up again in the future and remind parents that you care about their child's health and you want to protect their future health as well. Next slide. So in July, we're going to talk more about communication styles like the announcement approach and motivational interviewing, but this slide just gives you a taste of what a presumptive announcement might look like. Juan is 9 years old, which means he's due for his first dose of the HPV vaccine. We'll give it to him at the end of the appointment. This vaccine protects against 6 types of cancer. Next slide. So why do we heavily promote HPV vaccine starting at 9? There are many reasons, but this slide in particular offers some highlights that I want to share. So starting at age 9 offers more time to complete the series by age 13. It offers a stronger immune response. This was a key point for me personally as a mother of a 13-year-old daughter. I vaccinated my daughter at 9 because I wanted to offer her the best source of protection. Vaccinating before the first exposure ever happens, it decreases emphasis on sexual activity, it decreases requests for school-required vaccines, decreases the number of shots given at one appointment. This was a personal benefit, once again, for my daughter who hates getting vaccines. It helps us to get closer to our healthy people goal of 80% by 2030. And research shows that systems, providers, and parents are highly accepting of HPV vaccine at 9. We're going to talk more about 9 in a future session, but I wanted to quickly share these facts with you, especially as you start to identify interventions for your own system and clinic. Next slide. So now that we've talked about recommendations and age 9, let's take a minute and do a poll really quickly. So Katie, if you could launch that, perfect. So we're going to ask you a question. Does your organization recommend the HPV vaccine starting at age 9? Yes or no? Does your organization regularly train team members on making an effective HPV vaccine recommendation? And if you do, then I'm going to have you also share with us what percentage of your professionals are trained on making an effective recommendation. Okay, we're slowly getting participation. Thank you so much. So far, it looks like many of you are saying yes, you do recommend at age 9, which is very exciting to see. Many of you are saying only providers are getting the training on effective HPV vaccination recommendation. Say, seems like 76 to 100% seems to be the biggest amount for that last question as well. We're about 60% participation. Just give it a couple more seconds, see if we can get a few others to participate. All right, we can go ahead and end the poll and quickly just share out the results. All positive responses, so thank you all again for participating. We can stop sharing and we can go to the next slide. So last month we shared that a staff survey to establish baseline knowledge on HPV vaccination is important, especially if you choose provider recommendation or staff education as an evidence-based intervention that you want to implement. So these surveys not only assess knowledge, but they pinpoint if there's certain attitudes and beliefs, which is really important. Training and education can help to set the foundation or implementation of new processes for interventions. It ensures that all staff are on the same page, and successful systems regularly train their staff on HPV vaccination topics. And this can look like a formal training, like a motivational interviewing series, a 30-minute lunch and learn, trivia during a staff meeting, or HPV vaccination facts shared in an online newsletter. It just helps to keep the topic top of mind and a priority, not lost amongst many others. Next slide. So to support staff as they embark on increasing HPV vaccinations, we see many systems enhance their EHRs or EMRs. And so these interventions play a powerful role in improving HPV vaccination rates by making it easier for healthcare teams to identify, track, and communicate with eligible patients. These interventions can include updating clinical decision support tools to reflect HPV vaccination starting at age 9. It could be provider reminder alerts beginning at 9, an easy or automated vaccine ordering set, bidirectional interface with your state immunization registry, and even patient reminders via your portal. I do want to note that EMR and EHR interventions can be very timely and costly, so it might not be feasible for all of you to do, but they do help with standardization across staff and clinic sites, and they have lots of benefits to them. Next slide. An additional intervention that can be integrated into your EMR is standing orders. So this allows nurses, it allows practitioners, medical assistants, pharmacists, and others to administer the HPV vaccine without direct physician input at every visit, following those pre-approved protocols. Great intervention to think about. Next slide. And then whether you go down the path and make enhancements to your EMR and EHR, it's important to consider measuring provider performance with vaccinations. So provider assessment and feedback interventions both evaluate performance in offering or delivering vaccination to patients and presents providers with information about their performance in providing those services. Feedback may also be described as a performance of a group of providers or could be an individual provider and also be compared with a goal or standard. When you first do provider assessment and feedback, you may want to start with de-identified data to encourage everyone to get familiar with the idea of sharing their vaccine rates. And then you can move into making it identified by a provider or a clinic to make for a more friendly internal competition as to see who maybe has the highest HPV vaccine rate. In my experience, provider report cards can usually surprise a lot of staff and encourage change. Some providers may even ask you for an overdue patient list. So next slide. So I briefly mentioned provider reminders as a part of the EMR enhancements, but provider reminders don't have to be overly complicated. It could just be a physical reminder like a sticky note or a door flag letting a provider know that a patient is due for their HPV vaccine. This could also be reviewing and notifying providers of patients during the daily huddle, or even providing a laminated cue card for them to carry around in their coat pocket, talking about HPV vaccines. Next slide. So completion dose interventions weren't listed as a big bucket in our intervention slide, but I do want to share that some participants have asked for EBIs specifically around that second or third dose, depending on age. So I'm just going to quickly review them here now. So some things to think about are scheduling a patient's follow-up appointment for that second or third dose before they leave the clinic, standing orders to make it convenient for parents and guardians to get their adolescents in, having open clinic hours or partnering with an urgent care or pharmacy, utilizing parents' and patients' preferred communication method for reminders about that final dose, offering an incentive like a gift card to a local restaurant for completing the vaccine series, and lastly, using every opportunity to vaccinate. So incorporating vaccines into sport physicals or sick visits if you aren't already doing that. Next slide. Our last bucket of interventions is building community access, or access to care for short. Next slide. So the biggest thing to consider is reducing patient and parent barriers. Some of these interventions listed on the slide are not only reducing barriers, but can also be considered patient incentives. So in my experience, we see the most innovation from our rural partners when it comes to increasing access and reducing patient barriers. So some of these interventions that you can consider are open scheduling. So patients and parents can easily make an appointment when it's convenient for them. I mean, how many of you have had a light bulb moment sitting on the couch at 8 o'clock saying, I need to schedule so-and-so for this visit? Open scheduling allows for parents to make that appointment on the go. Offering walk-in appointments, this is where standing orders can come in handy. Offering vaccines at school initiatives, so this could be a back-to-school event, or offering vaccines at an established school-based clinic, extended clinical hours, or adding weekend availability, pairing the HPV vaccine with other seasonal vaccines like the flu, offering vouchers for those with transportation issues, and even waiving that administrative fee. Next slide. So now that we reviewed all the interventions that you can do to increase HPV vaccines, it's now time to go back through your capacity building and discovery phase to see what's going to be the best fit for your clinic and system. Next slide. So this worksheet in general is a great tool to use with your QI team to lay out all the interventions that staff want to implement. And then you need to start asking questions like, does this align with our goal? Do we have the resources to implement the intervention? Are care teams, team members going to be supportive, engaged? How will we test out the success? And once you've done that process, you'll start to eliminate interventions that aren't going to be feasible. I wouldn't suggest throwing them in the garbage, but keeping them on a dream board. You can always refer back to them and consider them for future use. Next slide. So before we move into PDSA cycles and sustainability, I just want to reiterate a few reminders about evidence-based interventions. They're best done in combination. Make sure to choose interventions that align with your goals and solve problems. Make sure to map out and integrate your interventions so you know how they'll fit into your process. Don't reinvent the wheel. This presentation in general gave you a lot of ideas to think about, and make sure you're getting consensus from all of your fellow QI team members before implementing the evidence-based intervention in your system. It's important that everyone's voice and ideas are heard. All right, we can go to the next slide. We're gonna do a quick poll and have you guys just share a little bit about your experience with PDSA cycles. So just give it here a couple of minutes, sorry. Slowly getting participants to join in. Looks like majority are saying no, they don't have experience using PDSA cycles, or they're not sure what a PDSA cycle is. I'm gonna give it just a couple more seconds. Hoping to get to 50%. All right, we can go ahead and end the poll. Thank you for those that participated. Like I said, majority doesn't look like have experience or aren't sure what a PDSA cycle is. We're just going to quickly review that here now. going to go to the next slide. So PDSA cycles are a four-stage problem-solving model used for improving a process and testing an intervention. The goal is to achieve a realistic and sustainable change when doing a PDSA cycle. So each PDSA often contains only a small segment or single step of the entire tool implementation. It's supposed to be short in time, so definitely a very brief, short time period, and it's supposed to be used in a small sample size. So it usually starts 1-to-1 and then grows from there. So during the planning stage is when you figure out what you're testing and how you'll measure success. During the do stage, it allows you to administer the test with a patient. The study phase allows you to analyze the data from your test. And then in the act stage, it allows you to refine the change based on what you learned. So did you love the results? Did you like them? Did you hate them? And based on what you saw, you may choose to keep the intervention as is. You may choose to refine it and test it again, or you're going to scrap it and try something else. Next slide. So once you've tested all your interventions, it's important to focus on sustainability. So you want to see HPV vaccinations increasing for years to come, not months, but like I said, years to come. The framework we've shared over the last two sessions has sustainability built into it because it's so systematic. It really helps you identify the best opportunities within your system. However, to ensure sustainability of your efforts, you're going to want to meet regularly. Maybe this isn't going to be weekly or even monthly, but quarterly allows you to keep HPV vaccination top of mind. You'll want to share progress with staff. Maybe it's during a staff meeting or shooting over an email on a regular basis to keep everyone informed. And lastly, if you haven't already done so, you want to identify a champion to keep the work a priority. So last month we shared you should have a champion in place, whether that's a pediatrician, a PA, a nurse, a medical assistant, a community health worker, who will be that point person for this particular project and goal. However, we know that staff turnover is a real thing, so be sure to identify a new champion if someone does leave. So now we are going to transition to a panel. So we are very excited to have a panel of experts who are going to share their knowledge and experience around HPV or around evidence-based interventions and HPV vaccines. So I'm going to quickly introduce everyone. So joining today is Oliva Carpenter, Associate Director for Community Partnerships at American Cancer Society. Cody Gilstrap, Clinical Nursing Administrator from UT Health East Texas Physicians, Sandy Hartman, who's also Associate Director for Community Partnerships here at American Cancer Society, and then Sally Wright, who's a Vaccine Coordinator at HealthNet. So I'm going to ask each of them to share a little bit more about themselves and how their work started to increase HPV vaccination. So I'll go with Oliva first.
Thank you, Ashley. Yes, my name is Oliva Carpenter, and I'm an Associate Director of Community Partnerships here at the American Cancer Society. And I live here in the Bay Area in Dublin, California. And a lot of my experience with HPV evidence-based interventions has come through my work here with the American Cancer Society. And most recently, I'd partnered with a community health center in Northern California, kind of rural, outside of Sacramento. And again, they serve both rural and Native American populations and were able to successfully implement a handful of evidence-based interventions last year in 2024. And the interventions focused a lot around optimizing their EHR, enhancing their staff training, and improving their patient reminder systems. And again, we were able to see a rise in their initiation rates in two age groups. So it was really great to see.
Perfect. Thank you, Oliva. Cody, if you want to introduce yourself and share a little bit more about your work with HPV vaccines.
Yeah, absolutely. My name is Cody Gilstrap. I'm the nurse administrator for UT Health East Texas. I oversee a little over 90 clinics for our East Texas market. We're a pretty large organization. As I said, we have 90 plus clinics in 110 by 120 square mile radius. The UT brand in itself is very large across the state of Texas, but I'm in our East Texas market. we have a lot of partnerships or a great partnership rather with the American Cancer Society. We work on a lot of different grant opportunities and things like that. But this opportunity was given to us probably about 2.5, 3 years ago, with the opportunity of focusing on HPV vaccinations across our outpatient ambulatory clinics, and I think it's gone very well. Um, so I'd be happy to share some of our experiences with that as this call progresses.
Perfect. Thank you, Cody. Sandy, if you want to introduce yourself and share a little bit more.
Hi, everyone. I'm Sandy Hartman. I am also an Associate Director of Community Partnerships. I'm based out of Reno, Nevada. And so I cover Nevada and the surrounding states. So I first got into HPV work when I was working in care coordination at a federally qualified health center. That role really gave me the firsthand experience into seeing the gaps in vaccine completion, especially when it came to the HPV vaccination series. So about 3 years ago, I joined the American Cancer Society as an associate director, where I now work directly with federally qualified health centers and community-based organizations across this West region to increase HPV vaccination rates. First, both first and those second doses. I also co-lead a CHW Echo series that helps educate community health workers throughout Nevada and the surrounding states on HPV prevention, vaccine education, vaccine hesitancies, and how to address them.
Perfect. Thank you so much, Sandy. And Sally Wright, if you want to introduce yourself and share a little bit more.
Good afternoon. I am the vaccine coordinator for HealthNet. HealthNet is one of the largest FQHCs in the state of Indiana. We have 13 health centers. Most of our health centers are in the Indianapolis area. We do have an office in one of our southern counties, and they do a lot of outreach to the underserved population there. As far as how I got interested in the HPV vaccine, I've worked pediatrics for 42 years. All vaccines are my passion. I have been around long enough to see these diseases on my patients before the vaccines were ever developed. So the fact that now HPV is a cancer preventative vaccine, I mean, who wouldn't want to line up when you say, hey, here's a vaccine to prevent cancer? So all vaccines are my passion, but HPV is definitely among the top two.
Perfect. Thank you, Sally. So now let's talk a little bit about interventions. I shared a lot throughout our three buckets. Cody, if you want to share a little bit more about the interventions that UT implemented and sort of how you guys chose them.
Yeah, absolutely. So we started off by, I guess, just listening to our patients and trying to identify what the barriers really were to their resistance or hesitancy to vaccinate their children. The one thing we kind of understood to begin with was we do live in a very Bible Belt type area. And so taking that into consideration with what we were hearing from the parents, which was a lot of times the parents kind of attribute this vaccination, this disease process with their child having sex. And if you look at the age range for the children that we're targeting to vaccinate here, when you start having those conversations, or this parents bringing their child into their pediatrician, at that age, and then we start having the conversation regarding HPV, which is a sexually transmitted disease, that puts a lot of fear on the behalf of the parents there. And so a lot of the parents were resistant with their children, especially with that age group, having their children vaccinated because of their thoughts was, okay, you're basically saying my kid's going to start having sex. And that's really not what the message that we were trying to put out. But we really needed to refocus that conversation with those parents and let them know that, hey, we completely understand that your child may not be having sexual intercourse today, but at some time in the future they will. And we want to get ahead of that and prevent that before it's a problem later on. Why wouldn't you want to protect your child today instead of dealing with a bigger issue or element down the road in the future?
Perfect. Thank you. Cody, could you share a little bit about some of the interventions that you guys specifically did to kind of combat some of those parent hesitancies?
Yeah, absolutely. So once we started hearing that, it seemed to be a common response in our clinics. We did a big, in the grant, we used a good portion of those funds to spend on marketing. We had digital advertising going, we had patient mailers, but we did a big marketing push on that, and we really honed in on um, that advice, that education, those statements that kind of pulled that focus away from the sexual intercourse aspect. And we saw that that really did help, at least put parents at ease, and it gave them time to really mull it over, really think about it prior to them coming to the office, and then we could approach it with them one on one in the office once they've already seen that and had time to think about it. Because one other thing that we saw is, when you put parents on the spot, we've all kind of been there at some point in life, regardless of what the situation was. But when we're put on the spot, and we're not prepared for it, a lot of times we have a tendency to react or be a little more reactive to it. And so that presented a barrier. So putting that advertisement out there, those mailers, those digital marketing advertisements really allowed, at least from what we saw, really allowed parents to really have that conversation in their head already. They're already thinking about it at some level. That way, when they get to the office, there's not that big shock value when we have this conversation with them.
Perfect. Thank you, Cody. Sally, I would love to hear a little bit more about some of the interventions that you have implemented and kind of how you selected them.
So kind of my thing now is we have friendly competitions between all of our health centers. And the whole goal, of course, is to increase our vaccine rates and protect our patients. So last year, just really brief on the contest I had. Um, the kind of the steps to doing that, you're going to have to get support and buy-in from senior leadership, facility managers, that type of thing. And then I set up vaccine parameters for the contest last year that involved the HPV. I also involved the Tdap and MCV4, so we can hit up all of our 11-year-olds, and hopefully they've got to have the Tdap and MCV4 anyway, and we're just going to kind of sandwich that HPV vaccine in there. So we had a contest. I named it the trifecta since it involved 3 vaccines. We run contests for 3 months. We never want to do longer because everybody loses interest after that. For this contest, we targeted the age group 11 to 15, and the specifics were they had to have at least 1 dose of HPV. We didn't do 2 doses because the contest is only lasting 3 months, so we didn't have enough time for that. And the criteria to win, is it going to be your most improved percentage up to date or the highest? So we did that. During that 3 months, we administered 1,062 doses of HPV in 3 months to 11 to 15-year-olds, and that's in 10 health centers that participated. And the contest-driven HPV rate improvement was 53%. So the greatest thing about the contest outcomes, of course, our patients are protected against HPV cancers. It improved our vaccine rates. We also increased our staff vaccine knowledge, which education to me is just huge. We improved the morale of the staff, and we increased awareness. Not only did we develop positive habits, but we also exposed our weaknesses. So,
Perfect. Thank you, Sally. You're
thank
getting
you.
lots of kudos. People are clapping their hands and sharing in the chat. Oliva, do you want to share a little bit about your partner and their interventions and how they sort of came to select them?
Yeah, absolutely. So as mentioned, the evidence-based interventions that they implemented included electronic health record enhancements, the provider reminders, provider assessment and feedback, so a lot of provider training and patient reminders. And these strategies were initially selected through internal discussions that they had, the partner clinic had, based on feasibility, staff engagement, and then alignment with their patient population. They did prioritize interventions that would generate the greatest buy-in and what would effectively reach their patients. And then again, this was an iterative process, so adjustments were made throughout the year in response to, ongoing discussions and internal meetings and kind of understanding what was working well and then what needed refinement. For their EHR, they worked a lot on their CDSS alerts to trigger for their providers. And then they had a lot of training around that for their staff to make sure that they understood and knew how to access those as well. So, yeah, there was just a lot of internal dialogue and buy-in.
Perfect. It sounds like they really took a systematic approach, so that's nice to hear. Sandy, do you want to share about some of the interventions that your partners have implemented and how they selected them?
Yeah, so some of the most successful interventions I've been able to work with our systems include school-based vaccine clinics during back-to-school events. So one of the systems that I work with in Nevada, CHA, they've been able to see really great turnouts because they're able to meet families where they already are and educate parents on site. Another system that I had worked with is Northern Nevada Hopes, and they offered incentives like gas cards and gift cards to really help remove some of those access to barriers and get patients to complete the series. And then the other system I worked with, Southern Nevada Health District, added reminder magnets and then post-vaccine surveys to help improve that second dose follow-up. So we measured success for these through vaccination counts during the events, feedback from those patient surveys, and then also chart reviews to start tracking at age 9. So those vaccination rates at age 9. And then we also looked at the provider and staff engagement to make sure that those interventions that we were helping implement felt doable. When it came to selecting these EBIs, it really always starts with the clinic's capacity and their readiness. So do they have that staff buy-in? Do they have leadership support? And then really a place for these interventions fit naturally. So we also look at community needs. For example, is there a transportation issue in these communities? And then focusing on local events and those incentives based on that. So a lot of our systems came up with that transportation issue. So some of the incentives were those gas cards to be able to incentivize them to come to these appointments and have that paid for. And then also going to these local events. So going to these community centers, going to the schools, or having some of these back to school vaccine clinics at clinics directly so that patients could access them. And then also trying to build on existing workflows. So for example, leveraging those dental visits. So working with our systems that already had a dental clinic and leveraging those partnerships there. And then also really utilizing those community health workers. So if we can track the impact, being able to adapt over time.
Perfect. Thank you, Sandy. Cody, I know you answered this in the chat, but there was a question around how did you get feedback from the parents? So I don't know if you want to elaborate a little bit more on the survey, that the after visit survey.
Yeah, absolutely. So across the board, regardless of what the situation is, and a lot of other healthcare organizations do the same thing, but we have after visit surveys that are sent out to all of our patients. It's typically in a text message. Sometimes if patients don't sign up for that, it's at the very least sent out to their email, but I'd say 90+% of them go out via text message. But we included some of those questions in those after visit surveys because we really wanted to hear from our patient population to see what was going on, what was their mindset, what were their fears, their reservations, their hesitations, all the things. And so that's what I meant by earlier when we were listening to the voice of our patients to see, what were those big barriers and how we could adjust course to get around those. So primarily it was those after visit surveys that were sent out to the patients that we got that feedback from.
Perfect. And I think it kind of reiterates what I shared before, like with reminders, like using the communication method that they indicate is their preferred, right? So you had it available via text, but you also had it via email and so on and so forth. So thank you for sharing that. And Oliva, there was a question. Oh, I'm sorry, maybe not Oliva. This would be for Sandy. There was a question that came in the chat about HPV vaccine in school events. So I don't know if you want to elaborate a little bit more how that worked, and if it's school required in Nevada specifically.
So the HPV vaccine is not required in the state of Nevada. So it's really just being able to work with the schools in the school district. So some schools would allow these vaccine clinics to happen on site. And oftentimes it's not just a specific HPV vaccine clinic. So it's a vaccine that's all back to school, where it's more of that sandwich approach where you're getting all of these in together. So they're coming in, these are all the vaccines that they're due for at this age, regardless if they're due for, if they're required for school. So because that's not something that Nevada requires, it's being able to leverage some of those other existing vaccines and being able to throw in or add on the HPV vaccine to those.
Perfect. Thank you for clarifying. So we have a couple more minutes, but wanted to see if all of you could just share a tip with our participants who are working or serving rural communities and selecting HPV vaccines, just something that they maybe should be thinking about, or something, just a piece of advice. So I'll go with Aliva first, and then Sally next.
Yeah, one piece of advice or my advice is I'd offer to start with listening and relationship building, really taking the time to understand the unique needs and strengths and talent and challenges of your community or the patient population, as well as your clinic staff. Um, Success with this type of work and EBIs isn't just about implementing the right strategy, it's about selecting approaches that are feasible, culturally relevant, and then have genuine buy-in from the people that are delivering the care and receiving the care. So designing solutions with your staff and with patients to ensure that the work is not only effective but sustainable.
Perfect. Thank you, Oliva. Sally, what is your one tip for all of us?
Maybe this is because my father was an educator, but I am huge on staff education. Um, really, if you're trying to, uh, I don't want to say convince, but I'm going to say convince a parent to consent to their child getting a vaccine, we really have to be able to sell that vaccine. If you're not knowledgeable, you're hawing around, you can't answer their questions, that's not building a whole lot of confidence with that parent and about the vaccine. So that's just my biggest thing, is the staff to be knowledgeable so that they feel confident and comfortable in answering the parents' questions.
Perfect. Thank you. Cody and then Sandy, what is your one tip?
Yeah, if I just had to pick one, I would say, communication and education, those really need to go hand in hand. I agree with Miss Sally on the education, but you also need to communicate and then educate, along with it. Communicate with your patients, communicate with your staff, and then educate, in the areas to, I guess, get over those barriers.
Perfect. Thank you. Cody or Sandy, sorry. What is your one tip?
Yeah, I think my one tip would definitely be meeting your community where they are, both clinically and culturally. And that can really be achieved by using your trusted messengers, your community health workers. So ensuring that community health workers are educated on the HPV vaccine and are also culturally educated on their communities. And by being those trusted messengers that are talking to the patients one-on-one or at community events, I think they're a really useful tool in ensuring that those CHWs have the appropriate tools and resources to convey the message.
Perfect. Thank you all so much for participating in today's panel and sharing your guys' experience with evidence-based interventions. I feel like you guys gave even more ideas for our participants to think about as they embark on picking things that they want to choose to increase HPV vaccine. So thank you all again, and I'm going to turn it over to my colleague Tina to wrap us up.
Great. Thanks, Ashley. And thank you again to the panel. That was amazing to hear, and I know everyone really benefited from that. We are going to launch a poll. Go to the next slide. Thank you, Katie and Hannah. Awesome. And so here's our post-session poll for you guys. So as a result of the session, next 6 to 12 months, how do you plan to use the knowledge gained today? And I know there was so much talked about, but how might you use that? And then which interventions do you plan to implement? And there's a whole list there for you. I'll leave that up for just a moment. I think we're good on time. All right, let's go to the next slide, which I think answers a question I just saw in the chat. So we have a really great landing page that has all of our informations on the monthly sessions, including recordings, resource roundup, and slides. And so we put the link in the chat for you. So if there's anything you're ever needing from any session, you can go to this page and hopefully find it as well. Next slide. We've shared a lot of resources during the call today, and if you were taking them down vigorously in notes, we do have them linked in our resource roundup, and it has been updated to share specific resources and tools to support patient-directed interventions. Next slide. And then we also have provider-directed resources as well. And so you can use these resources to support your work throughout the quality improvement framework, including aim statements, action plans, process mapping, gap analysis, PDSA cycles, sustainability, and it's regularly updated. So if you have a resource that you want to be shared in this, please contact me or Ashley, and or drop in the chat, and we can make sure to get this updated with your resource. Next slide. So this provides you easy access links to our ACS quality improvement tools, including the implementation manual and the evidence-based interventions toolkit. So you will have access to this as well with clickable links. Next slide. So as we recap and look ahead to July, we're going to focus on our upcoming session. So we'll be launching the first of our communication series, talking through the different HPV vaccination communication styles, including the announcement approach and motivational interviewing. So it's going to be a great session in July. And then for planning purposes, we can't stress this enough, but we encourage everyone to visit our website, and those new to the learning community, which I saw some new names, please check out the 2024 recordings to provide additional knowledge around quality improvement framework. Each session goes a little deeper into what was discussed in this session and last, and so you can dive in deeper as well. Next slide. And I just want to thank everyone, and we look forward to seeing you guys on July 9th. Next slide.